Hi, I'm Pat Bray. I'm the Community Relations Director with the hospital here. Appreciate everybody coming out at noon. I've been here since last July, and we've done probably 10 of these, and this is the largest group I've ever seen in this room. So I think we picked a good time and a good topic. I'll get out of the way and have Dr. AbouDaya come up. Dr. AbouDaya is a pulmonologist who's been in the suit for about 5 years?
4 years.
4 years. So we'll have him give his presentation. Thank you, sir.
COPD, it's kind of symptoms. Patient has to have symptoms and has to know whatever his symptoms, having symptoms, this is not normal. Let's say if I ask you, if the person cough, is it normal for the person to cough?
Yeah.
It's not normal. No, it's
No.
Normally,
Oh,
patients,
wow.
yeah, I mean, any person should not cough. And this is why when we talk about like symptoms, and we're talking about like lungs, we're talking about like cough, shortness of breath, and wheezing. This is the main symptoms. But majority of the, not majority, like up to 50% of populations, if you ask them, do you think if you're coughing every day, is it normal or not normal? They may not understand this is not normal. And they may not understand when they cough why you are coughing. So this is very important to know about like what the symptoms. And majority of the patients, as you see in later on, they feel like everything's okay. Unfortunately, they seek medical attention at what age? At advanced stage, when they already lost maybe like 50 or 75% of the reserve. If you remember the first slide, we have 2 lungs. By medicine, if we have 10% of good lung tissue, this good tongue, this is 10%. It's enough for you to give you like 100 years. However, mainly for a smoker or COPD, what happened because they continue to cough and they don't realize they are sick. They start having disease and they have to take care of it. So this is why they don't realize. When they come to the physician or to seek for medical attention, by the time they are not able to function or to maintain like function capacity, they are not able to walk, they are not able to perform like any activity. So then they come back and they check for medical attention, and unfortunately it's too late. And as you see later on in COPD, it's very important. The main step is to avoid. It's preventable disease. Try to avoid this. What time? Unfortunately, if you wait till you start having symptoms and bad symptoms, it's too late. But even though you still have treatment for this group. So look at this percentage here, it's about like 5 to 6%. We're talking about like 30 million person around us suffering from shortness of breath. And some of you are like, I'm pretty sure some of this room has some COPD. And you know what the shortness of breath? It's not fun to to wait for 2 minutes and you're not breathing. You're having shortness of breath. It's this uncomfort feeling. And statistic, we know that COPD, at least this is the first most common cause of death in 2012. In 2012 and 2013. By 2020, expectation to be the 3rd cause of death. Meaning if you have like 100%, you're talking about maybe like not 1/3 of 100%, because the 3rd most common cause. You're talking about like maybe 20%, 25%, or 30% of this 100%, they will die from COPD. They won't die from car accident and blah, blah, blah. They die from COPD. You know, this in the COPD, it affects men and women. Initially, they thought this is a man's disease. We know that nowadays, actually, it's pretty much close. A little bit more men's, a little bit more than women, because both smokes. But what's important to know, women are more susceptible to have more severe diseases. The likelihood, if you are, let's say, if you have men's and women, and you split this one, and you'll see like women goes to the hospital more often because of COPD. They suffer from severe and persistent symptoms and likely to die from COPD maybe twice the probability of the man. So let's say if you have like 100 women and 100 men. So you will see like 60% or 70% of women group, they go to the hospital very often. They suffer from more persistent symptoms. Quality of life, it's much worse in women group. And not only this, mainly depression, it's more in the women group. Let's see, let's go to the next slide. This is next. What's the definition of COPD? Why we need to talk about COPD? Not everybody coughs has COPD. It's not true. When we talk about like cough, we split. In medicine, we split. This is cough like for short term, like acute cough for like 1 week or 2 weeks, or subacute, like for like a couple months or 3 months, or chronic cough. This is a classification: acute, subacute, and chronic. It makes big difference because why? It's not the same disease. It's different category. In COPD, when we talk about COPD, like when the patient starts smoking, immediately it doesn't happen. Most likely nothing will happen immediately. But after a few years, like 2 years, 5 years, or 20 years, he may start having symptoms. There is part, the patient smokes, but no disease, but for the completely different from person who smokes, but he does have disease. Why it's important? Because of a lot of issues. One of them is life expectancy. Second, because the COPD can kill him. Second, function capacity, how active he will be. And it might affect the other organ as well. So in COPD, there is definition. What's the definition of COPD? Definition, you have you remember this lungs and you have airways, you have obstruction, you have blockage, you have resistance in the tubing. This is what they call, this is by definition, they call like COPD. But when you have this obstruction is permanent and continuous and not able to go back to normal, not fully reversible, what they call this? This is COPD. So this is like tubing, this is obstruction, it will never go back to the normal dimension. So, and this is different from asthma. What's the asthma? Asthma, it's close to COPD. People they feel like asthma is better than COPD for many reasons. Why? Because the asthma, I was born with asthma, so it's not my mistake. COPD, no, I'm smoking, I have COPD. You know what's the difference? So this is why if you ask what, do you have COPD or asthma? No, they choose asthma. It's okay, but it's not the same disease. Asthma meaning you have this tubing, it closes down, the bronchospasm, it closes down, but there is good chance for this to go back to the normal level. In COPD, you have obstruction, it closes down, but when it goes back, it doesn't go back to the normal level. So this is the COPD. This is part of COPD. So, and not only this, when we start talking about, and when we start talking about COPD, so we have to start preparing how meaning you're losing your lung reserve and how you protect your lung reserve, because we know by statistic, if you like when I start having symptoms, let's say I smoked for 15 years or 20 years, and now I start coughing, persistent cough, like persistent cough for weeks and months. So why it's important to tell me, Dr. AbouDaya, come and you have COPD? Because I'll tell you what, we know if you continue doing whatever you're doing, within 2 years, you can lose your lungs. From 2 to 5 years, there's a chance for you to lose your lungs. And if you lose your lungs, what's gonna happen? You die, that's it. So this is why it's very important. This is what I call it. We call it as alarming sign. Stop, pay attention, think, see what you are doing, and please try to take good action. So COPD, when smoke, or any we have other risk factor for COPD. When you start having a disease, you have to look at that. We know this is chronic disease. It's not going to go back to normal. I have COPD today, tomorrow I don't have the COPD. It doesn't work this way. It's not like an infection. I have pneumonia today, tomorrow I don't have pneumonia, I'm cured. No, COPD, it starts and it continues. What the issue here with the COPD, when you have COPD, you have to understand what it means. What it means, you should, most likely, most of the patients, even if you don't take any treatment, you do not experience daily symptoms. But what happens, you start having what? Flare up and down. This is the disease continue, but you start having flare up, what they call COPD exacerbation. COPD exacerbation, is it important to know about this or not? In medicine, yes. Because we know this is one of the signs as a physician, meaning this patient is suffering from COPD and his COPD is not well controlled. Why is very important? Meaning he's losing what? Reserve. He's losing reserve every day. And this is why and we know that if you don't take any action here, you will lose your patient. And the patient will die. So this is why it's very important to know what the patients and what the symptoms and how many exacerbation he got a year. We take it a year. Normally, we'll go, everybody like catch a cold once a year or twice a year. So this is why we accept like exacerbation, COPD exacerbation once or twice a year. But if you have more than that, meaning what? Meaning whatever you're doing or whatever treatment or whatever has been happened is not enough. Your disease is not well controlled and should be treated and better treated. Nowadays, honestly, we do have a lot of medications and very few cases, very few cases, we call it as difficult to control. Very few. Like if you go back to 1980s and 1970s, I'm pretty sure some of you remember this. You are seeing patient like in front of you, you don't have any oxygen on any equipment to help him, but he's suffering from shortness of breath. He's not able to move, but he's very, in severe distress, and he stay like this for maybe weeks, months, or some years and die. You see how it's very dangerous situation. So back to the definition. So definition of COPD, I want everybody to understand. The definition of the COPD is obstruction, blockage to the tubing. Not only this is part of the COPD. Where we are? Okay. All right. So when we smoke or we get exposed to chemical stuff or toxic stuff, this material, it doesn't go to the tubing only. It goes to where? It goes to the lung tissue as well. It damages the tube, but it damages the lung tissue. So when they look at the definition, if you have like a tubing problem, we know this is what they call like chronic bronchitis or COPD. But what happened to the tissue? The tissue here, we have different type of inflammation or damage. Okay, sure. If you have damage to the tissue, to the lung tissue, this is what they start talking about what? Wake up, guys. About emphysema. What's emphysema then? Then you have the main issue when we talk about medicine, when we talk medically, when we talk about emphysema, it's damage of the lung tissue, not inflammation. I'm talking from COPD, you have like, if you remember the first picture, you have two lungs, tubing, at the end you have sacs over there. The damage of this sacs they call like emphysema. But, okay. This is, I think this is the lecture. Okay, good. So, all right. Back to, yeah, this one. Okay. This one, yeah, this one. This is COPD. Okay. If you go back to this one, this is the airway here, and this is the airway. If you have damage to this part here, this is what they call bronchitis. If you have damage to this one, to the sacs, air pockets, they call what? They call emphysema. Sometimes this is both of them, it's COPD. But if you have, like sometimes you have combination, both. You have damage to the tubing and you have damage to the lung tissue. This is still COPD. So this is general term, they call like COPD. And this is in medicine, this is what it means. COPD means two, bronchitis, chronic bronchitis, not acute bronchitis, or emphysema. And it depends on the, or both. can go. Which one we have to use? This one? Next one, yeah.
There it
Let's
is.
go back, maybe there's some important slide. Okay, this one. Okay, so this is, okay, next slide, please. This is chronic bronchitis. I told you this is tubing. This is a normal tube. If you have asthma on this one, this is it closed down like this, but it opened up. In COPD, what happened? In COPD, look at the wall. It's thicker. Look inside. What happened? You have more phlegm. What does you tell me? You're not a physician, but what are the main symptoms of this person? Coughing. And what else? Doctor, I have a lot of phlegm, but I'm not able to cough it out.
Get it out.
Correct, because of the obstruction too. You have tube. To empty this tube, it has to be open. So this is bronchitis. What the definition of bronchitis? Make sure I have to make it clear. Chronic cough, not only one time, like people cough for 2 weeks or 3 weeks. Oh, you have COPD. No, it's wrong. You have persistent, because when we say this is COPD, as I said, this is chronic disease. It's kind of serious issue. Next slide, please. Emphysema. We talk about this. This is the normal, like when you have this is the normal tube, and you have vessels around these pockets here. When you have damage to this one, it's you have dead cells around it. There is no alveolar. There is no they're called alveolar damage. So what happened with emphysema? You get air from outside. It goes to this part, but you have oxygen to go to the blood circulation here. It's already damaged. What's this person's main symptoms? Correct. Shortness of breath. Shortness of breath. Correct. Shortness of breath. Next. And this is the same. This is the normal. But when we talk about emphysema and COPD, it doesn't mean you lost your lungs completely. No. You have classification. You have mild, you have moderate, you have severe. We'll talk about it. Next slide. This is emphysema. This is part of the lungs. As I said, I want to make sure you understand this one. This is a tube. If you have mainly tubular disease, it's bronchitis. If you have mainly lung tissue problems, like you see what the difference between this and this is a normal, and it's gone. And unfortunately, till 2013, what's the treatment of this if it happened? If we lose our lungs, there is no treatment. This is a scar. The treatment is lung transplant. It is not an option for COPD and for emphysema. So you lose your lungs, you die. That's it. Next slide, please. This is a little bit some picture about circulation. This is a normal here, you see. This is the tube, and this is the alveolar space. When you have damage, even circulation, doesn't matter how much you are able to blow out in and out. If you blow out 5 liters, okay, but your system is not getting any. You understand?
There's no oxygen transfer.
There's no oxygen. Exactly. There is no oxygen going from the system, from the lungs to your blood.
Yeah.
And what's the next step? Wake up. We said why we need to breathe. Oxygen and CO2. What happened to carbon dioxide? If you're not able to get circulation here, and you don't have any, you're not able to empty your CO2, what happened to your system? What happened to your CO2? Stuck in your body. What happened with high CO2? Very tired. You start losing your muscle. Even you start walking you are very tired because of what? Of CO2. And you go to sleep, you cannot sleep. You wake up, you are very tired because of CO2. And this is sign. When patient comes to us and we start treating him and the patient start breathing improve, what happened? He start eating better. Why? Because when you eat carbohydrate, you produce CO2. If you have lungs and you're not able to blow it out, what's going to happen? You don't eat. So this is why if you have COPD, uncontrolled COPD, what happened? You lose weight.
Sure.
Why? Because you don't want to eat, because when you start eating, you get shortness of breath. So you know yourself, you eat a little bit, you lose weight. When you get treatment, you improve, you feel better. What happened? You gain weight. So maybe you have to tell Dr. AbouDaya, instead to do gastric bypass surgery, just introduce some CO2 to the people. Okay. This is the next slide. Okay. So we're talking about emphysema. Emphysema, we have two parts of the emphysema. I mentioned about this. Emphysema, it can happen like, or we born with it, or we got it from whatever we are doing. There is entity, and it seems like it's very common. It's not very common, it's more common than different place here. I'm talking in Michigan. What they call like alpha-1 antitrypsin deficiency. What's the alpha-1 antitrypsin? Alpha-1, this is enzymes, like proteins. We have it normally in our lungs. This enzymes, the role of this enzyme is to protect our lungs. And when you get infection or cold weather, you go inside, in and out, you get some inflammation. This enzymes, one of the role of this enzymes is to protect our lung tissue, which, not the tube, you know now about the alveolar space, alveolar sac, to protect this. There is entity called like alpha-1 deficiency. Some people, they born with it, with the level low. What happened to this group? They develop emphysema. At what age? Early age, like 20, 30, 35, 40. But what happened of these people smokes? Guaranteed, you got emphysema guaranteed at 40 years. Instead to smoke like 20, 30 years to get emphysema, you don't need to do this. You have discount, 50%. You smoke 5 years, you get emphysema. So this is, and what the problem with this, unfortunately, is the same. If you reach emphysema, treatment option would be very limited. So it's very important to diagnose this group as early as possible. Why? Because we have treatment. We can give some treatment for this, what they call like augmentation therapy, that will give you these enzymes, and it's very effective, no doubt about it. A lot of literature. If, let's say, if we are in 1950s, maybe we don't have it. But now we have it and it's available. So, and not only this, this is genetic. We got it by gene. So this is why it's very important to check. We do it like routinely, but it's important to check it. And if it's not normal, you check your relatives. And you can pick up these cases at early age, like even at 5 years, 10 years, 20. So you save the life. And it's common. Like we're talking about like over 5,000. How many person? Let's say here in our county, let's say 5,000, 50,000. I mean, we have to have I think about like 10% walking around us. This is percentage, 10%, this is big number. Next slide, please. We talk about this prevalence. Next slide. This is, I will tell you some in the future here, where we are. This is 2013 here. In coming years, if you look at, this is the numbers here of COPD from 2010 till expected till 2017. The number of COPD is doubling. Why? Because a lot of reasons, but the main issue is smoking and exposure. So if you look at this one here, we are almost here. So in 2017, let's say today we have about like 12,000 COPD in this area. I mean, less than that. I think in Chippewa County, I think we have, I think about like 5,000 COPD. In 2017, it might be like a little bit higher, like 7,000 or 8,000. So whatever we are doing, despite we know a lot about COPD, believe me, it's not only here, everywhere. You see the curve? Whatever we are doing is not effective enough to, at least to get like trend down. Okay, next slide, please. This is men and women, like emphysema. This is mainly emphysema, not COPD. Don't get confused. This is pretty much close. Next slide, please. Risk factor. Risk factor meaning why we get COPD. Normally, if people born, no exposure, and no genetic issue, they should not have COPD. Why we get COPD? What's the cause? You know, cigarette smoking, it's common. If you're in 1950s, majority of the population smokes, because they don't know at that time, they don't know what the consequence. They know it's not good, but they don't know as much as we know now. So cigarette smoking, it's count still up to 80% of the cause of COPD. Like smoking is not only like whoever who smokes. No, second-hand smoking too. Smoke exposure is too. Age. We know when we get older, like 40 and older, we lose some very minimal reserve of our lungs. but you lose, this is considered as risk factor. Like this is why if you look at the COPD, like typical COPD from smoking, it doesn't happen immediately. It happened like maybe after like 10 years or 15 years or 20 years later, patients start having the disease. Other exposure is very important here. Like any toxic exposure, like coughs, like occupational exposure, any chemical cleaners, any cleaners, it's toxic to the lungs. When you deal with it, what happened? You inhale. So it goes to your lungs, it can give you inflammation, and it can give you some, what they call like COPD. Next slide, please.
Any hairspray?
This, sorry?
Hairsprays?
Sprays?
Hairspray?
Yeah. If some people, they are allergic to this. If they are allergic, yes, it does. Because what happened? What's the allergy? Allergy meaning you get exposed to something, but it triggers your inflammation. And this is why you feel like watery or runny nose, or sometimes you cough, or like some people, they may have like wheezing too. So this is briefly here, this is a risk factor. We know it depends on the gene. Everybody have different gene. This gene, it play an important role. Some people, like you tell me, doctor, I smoke like 50 years, but nothing happened to me. It's okay, but I'll tell you about, in medicine, this is board question. I don't know what you, if I smoke now, like smoker, meaning I have to smoke over like 5 years. If I smoke, it affects smoking per se. It might not give me the disease per se, but what happened? Smoking, it will modify my gene. It induces what they call like mutation, gene mutation. They change. So what happened? I give my gene to my sibling till the 7th generation, and my sons and daughters has high risk of allergy. If you smoke or somebody smokes around you and the sons and has some kind of allergy or difficult allergy, tell him this is from you. It's not the gene, this is from you. So why? And this is what it is. They do like what they call like gene modification or mutation. So smoking is not only you smoke, you enjoy your life. No, you are giving to somebody else. And actually up to the 7th generation. Go ahead.
See, I quit smoking 40 years ago. What does that have done to my lungs?
Okay. This is big questions. Can I answer these questions at the end? Because this is a very important question. So gene is very important. Doesn't mean if you take gene, you're talking about yourself or the sibling as well. The main issue is smoking. I think you understand this is smoking. Exposure, we talk about it. Infection. Even if for some reason, if you get like recurrent infection, if you get infection, respiratory infection, more than 3 times a year, infection, not inflammation. Let's say if we have cold weather outside, I go outside, I didn't put anything, and I take like very cold weather, and I get some runny nose or some sinus pressure or something, it's not sinusitis. It's not, this is not sinusitis, it's not an infection. This is cold issue or weather related. Or sometimes you're doing something, or farmers, or you have some pets or animals, you get exposed to it, and you have a lot of dust, you get a lot of dust, what's gonna happen? Because it's very dense inhalation, it might induce some symptoms. This is not infection. So if we have recurrent infection 3 times, real infection over a year, 3 times, this is recurrent infection. My advice is to check your physician, because we have to check what you're doing, something wrong at your environment or your immune system. Next slide, please. Smoking, you're gonna be surprised, I think, at this moment. Like wide average, national average, we have like 20% of population. If you go anywhere, 20% smokes. So if we have like 300 millions. What's that about? We were talking about like 60 million person smokes. In the Chippewa County, I think Ashley said about 30%. We have maybe 1.5 more than the national average. So we have about here, they smoke about 30%. If we have like 50,000 by 30%, we're talking about maybe close to 20, maybe less, about like 16, 17,000 person smokes. And if you smoke 1 pack a day, I want to ask you, what you expect? I mean, how much money they pay here to smoke? 50,000 a year. How much?
Yeah.
Can you imagine? Just think about it. If you smoke 1 pack a day, 1 pack a day, you pay about like over like 30 years, you pay almost $70,000. This is one person.
Is that today or years ago when cigarettes were cheaper? No,
Not today. This is today.
Probably double now.
Yeah.
Yes, probably double.
Yeah. And the interesting issue when you smoke, if you smoke like you buy your packet like $6, $5, but you pay $35, you're gonna pay for this on your medications because of the smoking. So effectively, if you smoke, you're gonna pay maybe about like $40 to $45. If you smoke 2 packs, $90 a day. You're spending $90 a day for 2 packs. Yeah, next slide, please. Yeah. Here in our area, so this is from 2008, 4 years ago, not really recent. So it's about like 12,000 person smokes here, and 25% of this got lung disease. This is by statistic. We don't see anybody, but we know this is a number. So you can make your calculation. We're talking about like 3,000 or 4,000. They do have the diseases here. And look at this here. If you smoke 1 pack a day, just 1 pack a day here in Chippewa County, you spend the whole week, like you spend about like, what happened? 15. Yeah, you spend about like $25 million a year. You see how much you pay money on this? 25. And actually the average is between, like by smoker, it's between 1.5 pack a day to 2.5. So this number would be the real number, if I like by estimation, you will be close to $50 million a year. If you get this money and you distribute it, you can do like, you can build like 3 hospitals. Yeah, next slide. Next slide, please. Classification. Why we need to talk about like classification? Classification is for 2 reasons. For treatment, which patient you choose to treat, you need to treat everybody? No, there is classification. It depends on the severity of the symptoms and a breathing test. We'll talk about later. Like mild COPD, mild, moderate, severe, and very severe. All this, it depends on what? What do you think? What's the idea behind this? It depends on the reserve. Because when you smoke, you lose. So for a smoker who comes earlier and he quits smoking and he take good, like the right action, what happened? He will have mild disease and he quit smoking for some reason, and then you will see later on the lifespan and quality of life and diseases and symptoms would be much, much less. And this is when we tell. If the patient like smokes and comes with symptoms, medicine, what we can do? We'll give medications. But if he quits smoking by medication per se, it does not do all the job. It does help like 15, 20, 25%. But patient still has to do other issue to help himself. Main step is to quit smoking and to avoid smoke exposure. Let's say medically we know if you quit smoking today, within 6 months, we guarantee your symptoms would be better up to 25% without anything, just to quit smoking. If you quit smoking over 5 years and nothing serious happened to you, your risk to have bad consequence from smoking would be very small. Never is going to be the normal, but is a little bit higher than the person who does not smoke. So make it clear a little bit on this. Let's say we have 100%. 100% smokes, 100% never smoked. If you continue to smoke on this 100 for like, if you quit smoking in 100% group, today, no difference between the, like from symptoms wise, in 6 months, the symptoms in this group who quit smoking would be 25% less than the others. But after 5 years and more, your risk is not going to be the same as the people who never smoked, but slightly elevated, maybe once or twice or 3 the chance to have problems more than the other people. So because you smoke, as I said, your chance will never go down to 0. But it's much better than you have like chance like 60 or 70, but you have maybe like 2 or 3%, which is not too bad. Next slide, please. No, I think you're going backward. Symptoms. Now you understand, if you look at the lungs, you have tube and you have lung tissue. It depends on the disease. If you have bronchitis, what are the main symptoms? Coughing, productive cough, and wheezing. If you have, and shortness of breath, but the main symptoms, it's coughing. Patient, doctor, I'm coughing too much because of the tubular disease. If you have lung tissue disease or parenchymal disease, it's mainly emphysema, meaning what? Doctor, I'm not coughing, I'm sitting okay, but when I walk a little bit, I got shortness of breath. This is mainly COPD. Go back a little bit. Yeah. We know by statistic, if you ask, like if you get 100% with COPD, you know they do have COPD. You ask them, how you feel? I'm feeling fine. Do you have any symptoms? No. 80% of this group, they said, I do not have, we're not telling them they are liar, no. But they don't realize it's not normal. They don't know. You remember, you're here, you're coughing, do you feel like this is normal? No, it's not normal. Like I have to mention this, like especially in kids. If you have like kids 5 years old and he continue to wake up at night to go to the restroom, it's not normal. It's not normal. This is, and we know this is kind of kidney problem. So people, or even the kids, at age like 5 or 10 years, they feel like everybody goes at night to wake up and go to the restroom. It's not normal. So I'm mentioning this because it's important to know. Next slide, please. Okay, how we make like how we diagnose COPD? Go ahead, please.
2 slides back, I just wondered what the percentages were for stage 3 and 4. Go back 2 slides. I think I have the.
Yeah, go back.
Yeah, for 3 it was 30 to 50.
Oh, I
Stage 4 less.
I see. We have 2 main systems for classification. How you classify mild, or moderate, or severe, or very severe. Percentage from COPD, you mean? Or how? Oh, this one percentage.
Stages of COPD.
30%, 30 to 50,
Yeah.
and so this is how tight is it? You remember this?
Right. I just didn't see the numbers.
Okay.
Yeah, but that's not the percentage of people who have.
No, it's not the people.
No.
This is
That's
the
how
how
much
much,
is affected.
how narrow, and how narrow. What's the percentage of narrowing,
Right.
or of obstruction? This is what they call it.
Thank
Yeah.
you.
Yeah. Next slide. Next slide. Okay. How we make diagnosis? The main diagnosis is symptoms. And as I said, like symptoms, you have a lot of diagnosis can give you shortness of breath, cardiac issue, vascular issue, hypertension, a lot of other issues. So, but together, if you have wheezing and coughing over like 3 months, this is most likely, this is a chronic bronchitis, this is a disease. Why is it important to know? I think you understand why it's important. Second, to confirm, we do breathing test. This is very simple test, breathing test, to check this percentage, how narrow is, how much resistance you have in your lungs. And this number is very important. Not only important to know you have COPD, to know about your reserve. What else? Treatment. Because the pulmonary function test give us a lot of information about your lung function. And based on this number, we believe whatever you're telling us. But sometimes if you get a number, it's easy to treat and is easy to estimate. And you can tell. And not only this, we do breathing test and you start the treatment. As I said, COPD is a chronic disease. It's not enough to come, take treatment, that's it, done. No, it's not like this. You do, and you follow up with the breathing test every year or 2 years or 3 years, and to see where you are. If you continue, if this number continue to drop, decline, whatever you're doing, my advice, do not wait. Tell doctor, I think there's something wrong here. Who's responsible, you or me? So try to, otherwise, if you, as I said, like from COPD, we know, and this is no doubt about it, you can lose your lungs even from like 50%, like if you have even 50 or 60%, you can lose to 10% within a couple of years. Chest X-ray is very helpful as well, but you can make diagnosis on emphysema on the X-ray. But sometimes you may have like small damage to the lungs, but your lung function is still okay. So doesn't mean you continue to smoke. No, you're losing some reserve. This is a sign, alarming sign. Next slide, please. This is very important slide here. I want you to understand that this is life expectancy, and this is without. This is a little bit, this is a study done, this is over 14 years, follow up for 14 years. Wake up, is not allowed to sleep, guys, here. Okay, so this is based on the stage 1, 2, 3, 4. Stage 1, like how bad is the COPD? Look at the normal person, like this is a group, this is the one who does not have COPD and never smoke, this group. You see, from after 14 years, this is after, I think this is at age 50. 50 years old, they collect this group, and 50 was 14, we're talking about like, I think, yeah, 50. About like 64, which is not the 64, this is middle age. Now the average is, women is close to 82 to 84, man is close to 79. So even this is data, we're talking about like 64. So we're talking about like middle age group. Look what they found on this. It was very interesting study. This is done, if you have 100% here, was never smoked, most of them, they live like 12 years or 14 years, like about like 80%. So if you're 50 years old, to reach 65 years old, you have chance 80%. 80% from this group live 14 years. Look at the stage 1, even stage 1, and early stage COPD. What's the early stage COPD? You got the number. Low number, it's still very mild restriction. Look how much, if you start your symptoms here, in 14 years, you lose like, almost like they die like about like 65% still alive. How many person died? Like almost like 35%. You see, even stage 1. If you go to stage 0, stage 1, stage 3 and 4, actually stage 3 and 4 here, if you follow this curve, if you quit smoking here, we'll come to this. But if you continue to, this is a group, continue to smoke, continue to smoke, continue to smoke. When you lose 50%, like when you get like stage 3 and 4, you see there's no big difference here. Because what happened in this group here, you know, it doesn't matter whatever you do, your chance to die, it's
You're gonna die anyway.
chance, no, you cannot. But the chance to die, it's big. And this is what we're talking about, like moderate to severe COPD. Did you get it? So what this picture tells us, it's important to know from where. If I'm COPD, I would like to know from here when I'm stage 1, because I can make decision. But if I wait till you get like stage 3 or stage 4, it's not too late. You still, I'm gonna show you a different slide. You still have chance to improve to expand your life, but it's not as good as if you make decision at early stage. Yes, you have a question.
Is that just if you smoked, or is that if you've also been exposed to smoke?
This is mainly this group. This is a smoker.
Okay.
Yeah. Next slide, please. This one. I love this slide. Please be careful with this one. It's very important. This one here. This is expected. This is the life here. Years 25, 50, 75, and above 75. Even this is. I think this is from 2010. This slide is not. We have 3 years. But average. We know like life expectancy average is women, as I said, like 82 to 84. Man is 79. So we are here. This is the average. Average meaning 50% of population. So this is, if we have one like, this is the percentage on the severity of the COPD. This is the COPD here, and this is how many years. If you like at 25 years old, you got 25 years old, they start smoking. Most likely the smoke per se, it does not kill this group immediately. But if this group continue to smoke, let's say we have 100%, 25 years old, 25 years old, this is group smokes, this group never smoke. Follow look what happened. When after, even before reaching 50 years, even before 50, we're talking about like even 30 years or 4 years, look what happened. This group who never smoked, they continue, even like you lose some patients here. Is it surprising or no?
No.
This one, you see this one here?
Yeah.
You look at this one, this is never smoked, still alive. How many person you lost here? Let's say if he had 25 years here, 25 years old here, now he's 50 years old, maybe 2% or 3, like about like maybe 5% died from this, not from smoking, not because of COPD, from other causes. Look at what happened to this group here. Like about like at 50 years, 25% of this group die from smoking. What's the factor between these two groups? It's the smoking, right? So this is, look how much, even at 50 years old. So if you go back to here and you, in real life, you will see a lot of people losing, I mean, they die at 50 years old. They come from maybe for belly infection, from any infections. But the main factor in this group is not because of the infection, because predisposing factor, because of the smoking, what they call like contributing factor. And if this group, you reach 50 years old, and you continue to smoke, here you start having the disease. This is the COPD. This is normal. You don't have COPD. Here, you start having COPD. Mild COPD here, if you continue to smoke, you start losing what? Lung function. You start losing lung function, lung function, lung function. The average, like almost 100% of this group die at what? At below age 75, like 65, 70. What's the average? Average, I told you, average here. So anybody who smokes, like what they call like heavy smoker, over 10, or 15 or 20 years, he smokes like 20 years, and he continue to smoke, most likely what happened, what I'll tell him, this is the picture tells him, you lose between like 7 to 15 years from your life. We're not talking about quality of life, because this group, and COPD, and he may need oxygen, he may need a lot of treatment. We're talking about like numbers, life expectancy. So this is very important slide here. So you see, if you continue to smoke and you're not winning, it's fine, we respect the decision, but you're losing, you're paying the price. It's not for free. Look at this number here, which is interesting. If you reach like 50 years old and you smoke and you decide to quit, how much you win without medication? This is life expectancy at close to 10 years. It will never go back to normal. This is a normal level. You still lose some years, but you don't lose like maybe 15 years. You lose maybe 5 years. So it makes a big difference. And even at the end, okay, doctor, I have severe COPD. Why are you asking me to quit smoking? We look at this number here. Even if you have severe COPD, here it's severe COPD. He has very tight airway. Even if you quit smoking, this number is about like maybe 7 years, around 7 years here. So you still have chance. But unfortunately, if you start having respiratory failure, you're at the end, your oxygen is low, your CO2 is high, and it doesn't matter whatever you're doing, effectively this is the end. So this is a very important slide. Everybody understand? Any questions?
Well, quitting smoking is all up to you, because I quit cold turkey, and if I can do it, anybody can do it. That's the way I look at it.
Next slide, please. This is, okay, so when we smoke, our smoke, it doesn't go all the way to our lungs. What happened? We take oxygen. Where the oxygen goes? To anywhere, right? This is the same. I was looking how many toxic material in the cigarette we smoke, regular cigarette. Till now, we have like about, I think, 4,000 substance exists in the cigarette. It's very toxic to our system. 4,000 in each cigarette. Imagine this number. And this is a brief, and eventually when we die, the heart has to stop. But this is briefly how the smoker, COPD or not smoker, COPD or die. Majority of them die from respiratory issue, respiratory failure or something. But look at these numbers. Heart disease. This is like almost like 500,000 person. Like almost like maybe less than 1/4, like heart disease. And now, if you go to your heart doctor and you have chest pain and you have COPD, this is part from your COPD. This is what they call like COPD. It's chronic disease. They call like a chronic inflammatory disease. What it means it irritates your immune system. Your immune system fighting with the smoking all the time, 24 hours, continuous. And from the consequence is this, because when we have like immune system, we have a lot of other factor, like what they call like cytokines. These cytokines are toxic to your organs. Like everybody knows about autoimmune disease. What's the autoimmune disease? Autoimmune disease, like your own immune system, instead to fight against infection, what happened?
So it's fighting you.
Correct. Fight your own organ.
Yeah.
So this is the same issue because this is a battle, this is a fighting. What happens when you have a chronic COPD? This is chronic inflammation. Nowadays they call it like chronic inflammatory disease. Why? Because your immune system is continuously active. It's fighting. And because of the actives, immune system produce a lot of proteins, and they call like cytokines. This is very toxic to your vessel and to your organs, to your kidneys as well, even to the brains. So what happened if COPD was continue to smoke and he's not well controlled and he goes to see his cardiologist, ask him. Doesn't matter how smart is a cardiologist. If you don't stop smoking, this is the consequence from smoking. They put stents, they put a lot of stuff, but it's not going to work. Maybe it expands your life a little bit, but you're still going to pay the price. So it's very important, and this is why it's very important. Heart disease and COPD are part of the COPD. Cancers, look at this number. It's higher than the heart disease. And I think nowadays we don't need to talk about like statistics. We know cancer is very common in like lung cancers, other organs cancer like GI, brains, a lot of huge data on it. Lung disease, infant death. Infant death, like meaning if we give it to the, let's say if I'm a smoker, my kids has risk for 7 times risk to have infection. Normally in medicine, if you have normal organs, you should not have sinusitis. You should not have pneumonia because your system is good. But when you start damage yourself by smoking or smoke exposure, and don't forget about like when you smoke, you change the gene, you affect your immune system. I'll tell you from now. I'm intensivist too. When we got patient critically ill, what I'll tell, listen, we're not God. We'll give treatment. We'll give antibiotics. Whatever we are doing, it will help like 20-25%. All the other 75% has to be done by whom? By your immune system. By your system. If your system is not fighting with us, we'll help you like for 2 days, 3 days, 4 days, 5 days, but at the end, that's it, done. So this is why the point here is to understand what we are dealing with. Understanding it makes big difference. So next slide, please. What we can do to face COPD. Yes, go ahead.
I have a question about, I saw a program, third-hand smoke, talking about, for example, a parent who's a smoker, and they go outside and think they're doing a very good thing, they're not smoking in the home, but then will come in, the same clothes on, and pick up a child. That was one of the examples given of talking about looking at the concept of third-hand smoke.
Correct. This is third-hand smoking. That is correct. And even though, if you like they said, there is not as second-hand smoking. Second-hand smoking. Let's say if you live with somebody who smokes, you got like 75%. Maybe he smokes like enjoys smoking. He got 100%, but you got exposure like 75%. In third, smoker from not second-hand smoking, you can get like not as high as 75, but less than 25%, but still consider it as a factor, and especially with the kids. Let's say, and notice by especially in the pediatrics, what happened? The family smokes, mother, father, and they go somewhere else, and they come back. Even though when you smell smokes. This is what? This is toxin. It goes to where? To the babies, and after a certain time, it will increase the risk of airway disease and COPD. And it does exist. Sometimes when patients comes to us, he doesn't smoke, he never smoked, his parents never smoked, and they got like COPD. And this exists. We do not have, they call like obstructive airway disease or even COPD, but without like identified cause. But we know, if you ask me if I want to guess what the main issue here, I would say this is smoke exposure. How? If you go back on these patients and you ask him specifically how many times, what he was doing before school, even as a school, what he was doing, casino and stuff like that, all this exposure, it does count. Okay, next slide please. This one, what we can do. Yes, go ahead.
What about the unborn? Unborn that's exposed to other smokes?
It does. It's not like direct toxin, but we know it increases the risk of gene. Don't forget about gene. Smoking, it modifies the gene, and this is why, as a pregnant woman, you know, when a patient comes to us, we'll ask, you have choice to smoke or not to smoke. As a, like 1 year old, let's say, you have choice not to smoke, but we don't recommend you to smoke. This is what it is. You lose, blah blah blah. For pregnant women, if she smokes even few cigarettes a day, this is considered smoking. Because what happened, all this, it goes to the babies, and this is at the beginning, so it will affect what? We're concerned about what? Quality of a gene. And this is what I talk about. If this baby born, and you will see, and this is common, a lot of allergic reaction to this patient. Oh, he's allergic to everything. No, this is your mistake. This is you did for him. And I tell the patients, like when we ask and we have like cases like this is not his fault, this is your fault. So please be careful. So,
what do you tell a person that's on oxygen and smoking? What do you tell them? They're committing suicide.
You're gonna blow up. You're gonna blow up.
They're committing suicide, right?
this is a suicide.
Huh?
This is a suicide, exactly.
Yeah.
You see, this is, I mean, he's already like, it's like he's killing himself. And not only this, he's paying a lot of money for nothing. So education is very important here, because as you mentioned earlier, when you decide to quit smoking, is not how much. I know everybody, if you want to Google like to get more information about smoking, you get a lot of information. Even Google it, you will find a lot of information, and it's available. But what the most important issue is understanding, education, understanding, and make decision. Everything comes from here. As a physician, believe me, it's easier for me to come. Okay, this is your medication, go. But the most important, to try to talk and try to convince you and try to do some change and try to change these factors. And this is the most important. But unfortunately, we cannot do everything. Even medication does not do everything. The main issue here, it comes to
Right.
here.
Right.
So this is why even the way you talk with the patients is very important. Even when you decide to quit smoking, you come patient sick, oh, I'm dying, I was having shortness of breath. Do you think, I will tell you this later, but if the patient's like having like shortness of breath or coughing, you ask him, you smoke? Yes, but I'm quitting now. Okay, this is good. At least he's thinking smoking is not good. But we know if he quits smoking today, almost 90%, 95% they will smoke in a couple of weeks. But if the person comes and he's not sick, he comes to you, tell, I'm ready to quit smoking, we know this group, they do much better. And majority of this group, they quit smoking. So it goes with from here. What I will tell, okay, you enjoy smoking for a certain time, for 10 years, okay. Now you start paying price, now you start losing your lungs. You have to choose which one, lungs or cigarette. You choose. Unfortunately, it's not like an option to choose both. It's not exist anymore. So you have to choose one. And this is the person. Majority of them, they will, if like education, it does make difference, and it saves a lot of money, and lives and money actually. To avoid triggers. Triggers we talk about like exposure, any type of exposure. And majority of the patients, let's say if you're allergic to anything, do you think you don't know? You know. Just focus a little bit. Initially, like in the 1950s and 1960s, 70s, they do have they used to work a lot, like exposed to a lot of chemical stuff, and some of them, you know them. Oh, I don't care, I have good lungs. But 10 years later, you will see these people die, and they start realizing how bad is the occupation, smoke occupation, and exposure, and all this stuff is bad. Exercise. Illness, infection. To avoid infection, unfortunately, infection or bacteria does not respect us. Goes, attack you. So, but there is some issue here. Till 2013, I think like vaccination is very important. A lot of literature supporting vaccination, especially flu shot and pneumonia shot, if you're not allergic. Indication till now, if you have like any airway disease like bronchitis or lung disease, it's recommended because it will decrease the risk of infection, the total number risk, and if you get the infection, the same infection. I'll tell you what about flu. Flu, you have many types of flu. It's not only one type. And you know it shift. When we talk about flu, this is one type of viral illness. But how many virus we know? Maybe few. But how many virus does exist? Maybe billions. So it doesn't mean if you get flu and you get viral illness, oh doctor, it didn't help. No, this vaccine, it works against this type of virus. The same issue with pneumonia vaccine. Pneumonia vaccine, it works mainly about streptococcus pneumoniae. This is kind of bacteria. This bacteria responsible about like 35% of the pneumonia, of the lung infection. Not 100%, 35%. When you take pneumonia vaccine, and not enough, you take pneumonia vaccine, you have to have immune system working to memorize. If your immune system is down, it doesn't matter how many vaccine you got, it's not gonna work. So you have to have good immune system to memorize this one. And we don't need to check immune system on everybody. What's the recommendation? Just give it, because the consequence is not very bad. And actually it's better. So just we provide it and to protect. And if you get pneumonia vaccine, theoretically, if you get pneumonia vaccine, it will protect you for 5 years. What it means, it protects you, meaning it does not, in medicine, nothing 100%. You do it, I guarantee you it's not gonna happen. No, it doesn't work this way. But it will minimize the side effect. All right. Next slide, I think smoking, I think quit smoking is important. We talk about like, has to come from here. Whenever you're ready and your brain process this one, I think you'll be able to go through it. Next. Unless we talk about it, next. Triggers, I think we talk about it, next. Nutrition is important. How we breathe, in and out oxygen. We need oxygen, we get it from outside. But let's say if we have limitation with the lungs and your body's size is very large, what's gonna happen? You need more oxygen and you produce more carbon dioxide. Don't forget carbon dioxide. Carbon dioxide in pulmonary is more toxic than the oxygen, because if your oxygen drop a little bit, you won't stay at home. If you drop a little further, you go to the ER. But if CO2 goes up and down, you don't even realize. You don't know. But you feel like you're sick. So if your body size is very large, so you need more oxygen and you produce more carbon dioxide. So it's not good. So especially if we have good lungs, not maybe it's okay for Dr. Adair. So he got but not because obesity has a lot of bad consequence on the heart, blood pressure, strokes, and other comorbidities. So, but in COPD, especially in COPD, if this is moderate to severe COPD and the patient is symptomatic, that most of the patients, they know, as I said earlier, they notice if they eat more or they maintain good body size, what happens? They got more shortness of breath. What they do, if they don't want to go to the physician, they don't eat, they lose weight. And they know if they lose weight, they feel better because of the limitation of the lungs. So, and not only the body weight, but other issues, the quality of whatever you're eating. Whatever you're eating, it makes difference, because how we generate CO2? By eating too. Activity and eating. If you eat more carbohydrate, you produce more CO2. In 1970s, why we don't overfeed patients in the hospital? Maybe it's good, no? What do you think? Just instead to give like 2,000 calories, give like 10,000 calories. And they did it. They did it in 1970s. The hospital would be better, patients happier, so why not? So what happened to them? No, this is real. What happened? The patient died from respiratory failure. They come with appendicitis and infection, but they die from respiratory failure. Yeah, this is real. It's and they said, "Oh, stop, go down." So this is why it's important. The same issue with the COPD, and actually, if COPD and sick and symptomatic, most of them they don't eat because of two reasons. Because of the active inflammation, make them lose appetite. Number two, shortness of breath. When they eat, they get more shortness of breath. So the quality of regular healthy food is good. The idea behind this, minimize carbohydrate and body weight. Next. Medications, I'm against to treat yourself by medications. This is not the majority of them. Even physician, I will be honest with you. If you get the physicians, 100 physicians, and ask him about this medication, some of them, maybe I don't know how many, they may not have. If they don't treat this disease, let's say I'm not a surgeon. If you ask me about surgery, I may have some knowledge, but I'm not treating that. I do mistakes. So this is the same issue with the patients. Even for myself, I don't treat myself. Because there is reason behind this. Reason to read some information here and there, it's okay, but medicine is not like this. Medicine, you have to have like study, what they call like evidence-based. What we know for sure, it does help you. Otherwise, how we can know? We have, let's say for medication, maybe we have like 20 medications. How come I choose this one and this one? Do you think I like the name, or I remember, or do you think this is right? No, it's not this way. We look at the study. What they call like evidence-based. We look at it, and this is what we should do. If we're not doing this, we're doing something wrong. So especially for the patient, we don't recommend for the patient to treat. Oh, you take this one, but what the recommendation is to follow the instruction. It's okay to read the brochure and instruction. If you have questions, go back to your doctor. Because some of these medications, all the inhalers has some side effects. Side effect. One of them is what? Like heart disease, gastroesophageal reflux disease, like heartburn, like acid reflux. It increases a lot of constipations, a lot of sleep issue. Heart, it might affect your heart. So all this chemical material, and even how many times you use it, the way you take it. Inhalers is not like this. Now you know a little bit about the anatomy. When you take inhalers, this powder has to go to where? To the lungs. If you're not able to suck it all the way down, doesn't matter how much, how good is the medications, but it doesn't work. Next slide, please. Next. Pulmonary rehab, exercise. How we breathe. This is we need lungs to breathe. You need lungs. You need what? Air, and you need muscle. If your muscle is not working, what's going to happen? We won't be able to. You need to generate negative pressure. We can. If our muscle is not good, what happened? And I'll tell you what. You realize this. COPD have shortness of breath when you're doing something. What happened to you? What you do? You sit down. You don't move. If you sit down, what happened? We know in medicine, if you got like good muscle, like 20 years old was good muscle, you put it 3 days in bed, don't do anything, you lose how much? 25% of the muscle strength. 25. Imagine a COPD who's not moving at all, and he's sitting down for a whole year. What's going to happen to his muscle? Correct. So exercise is important. Till now, pulmonary rehab, 85%. If you have moderate to severe COPD, 85% of the COPD, they report good outcome. Good outcome. They are able to function over like 20 or 25 minutes. Majority of them, they do more, like up to 40 minutes. Number one. Number two, they maintain good oxygenation. Like instead, like you stand up and you walk, like immediately you get to stop. No, they are able to walk a little bit more long distance. We know in exercise, it improves the quality of life. It improves the emotional issue and psychological issue, but it improves the risk of infection. Why? Many reasons, but the main reason is this: if you have phlegm in your lungs, what you do? You cough it out, right? Up, right? To cough it up, what you need to have? You have to have cough reflex. How you cough up? You need muscle. This is what. Most of the COPD, if they are not moving at all and sitting down and breathing like very shallow and sitting, is not good, because even if they do have some phlegm in the lungs, what happened? They're still there. What happened if they maintain this phlegm? Bacteria loves this because it sit there, loves everything. They are very happy and they grow up. And what happened to this person? They got more infection, and what they call in COPD infection, exacerbation. COPD exacerbation. This is why we recommend for any. This is for even for 20 years old. recommendation nowadays is to do exercise like 30 minutes, 5 days a week. This is at least. You can do as much as you want. But COPD is the same, pretty much the same. But we know in COPD, if we have the disease like moderate to severe, you have some limitation. Joint disease, heart disease, back disease, and and sometimes oxygen issue. All this we have to take it into consideration. What we would recommend in the lungs, when we talk about lungs and muscle, upper body muscle, right? You don't want to, if you have good muscle in the arms and legs, good. But when we talk about COPD, you need the chest muscle. We know from exercise like swimming and water exercise, it's excellent, it's perfect, give you a lot of, if you can tolerate it, if you're like good, better outcome, but other exercise as good as well. What? Next. This is, okay, this is important, this is a little bit crowded here, but doctor, okay, I'm coughing. What time I know I have to call physicians, or what time I have to go to the ER? Briefly, and common sense is common sense. Most of the COPD here, they know what the usual stuff. Even for a normal person who does not have any symptoms, let's say if I get sick 1 day, 2 days, or 3 days, or sometimes I'm a physician and get sick, like, and I'm not able to move, and I don't know what's going on. There is something serious going on here. I have to go to the ER or ask my doctor. But for COPD, you have some symptoms here. Any significant changes of the symptoms, most of the patients, we know, they know, and they tell. Because what happened, let's say shortness of breath. They know if you walk like 50 feet, you get shortness of breath. But next day you walk like 2 feet and you get shortness of breath. And later on, you're sitting down, you get more shortness of breath. You notice this. If you get this worsening symptoms with short time, then you have to speak with your doctor. And especially if you have like unusual symptoms, like you feel like you're losing your control, or you're very fatigued and you're not able to wake up, this is a sign of, especially in COPD. If the oxygen drop, what happened? You get shortness of breath. You don't wait, you go. But if you get tired, very tired, and you're not able to wake up, it takes like, normally you wake up, CO2, good. Yeah. In the morning, it takes me like 5 minutes to wake up. Today, 20 minutes is not waking up. 30 minutes is not waking up. This is very lethargic. What? This is CO2 retention. It's very toxic. Okay, so absolutely, if you have like bad chest pain or like unusual symptoms, I would recommend. I'm not like as I said, like the main key here is common sense. Symptoms. We're talking about like a group who does have like daily symptoms, some kind of daily symptoms, but majority of the patients, they know. If you have like absolutely, if you have, let's say, patients not waking up for like half hour or something, and it takes, or he's not able to remember, or he's not able to concentrate, there is something serious here. So you have to check with your doctor. Fever. Fever in medicine is not 99. It's like significant fever, 102 and 103. If you have persistent fever, like over 3 days, and you feel like antibiotic is, believe me, whatever antibiotic, oral antibiotic, it works. You can try it once if you feel okay. I know some of the physician, doctor, give me antibiotic, and I know I feel better next day. And this is not bacterial infection. This is not the antibiotic. This is your immune system. If you have real infection, it does not respect you. Believe me. Infection, it's infection. If you don't hit it, I mean, on the right antibiotic, it doesn't work. How many antibiotic we know? Maybe some. How many bacteria does exist? Billions. So this is one. And I'm telling you now, we have like what they call like ESBL. We have flare-up. In 1980s, in Europe, kids comes, doctor, why I need to think like twice? Is it infection, viral, blah, blah, blah. Just give him antibiotic. 1988 and 89 and 90, what happened? They got resistance, flare-up. There's no antibiotic to work. Everybody went what? IV antibiotic. And how many IV antibiotic you have? Do you think you have billions? Limited. And what's gonna happen? You lose this, and that's it. And we, in previous program, we used to burn body once or twice a month. From bacteria, we have it here, but it's not as bad as in New York. I came from New York, but this is, why? Because of the antibiotics. So bacteria, to deal with the bacteria is kind of not easy, but then in medicine we have to follow certain rules. Next slide, I think. Conclusion, COPD is a preventable disease, a treatable disease. It can present with mainly with, as I said, vestibular disease and parenchyma. You know about, and it's very costly, like to smoke by life and money-wise and life-wise. It's very important. And the main issue is education. Education for the medical team and for the patients and for the community as well, actually. Any question? Back to your question. I think I answered your question, right? About yeah. Okay. So then the risk, if you smoke, let's say, if you smoke 5 years and less, most likely you do not have. What's the consequence of less than 5 years? We don't know, really, we don't know. It might not affect your symptoms, but does affect your gene? We don't know. If you smoke, like, this is what they call, like, what we are concerned from medical, if you're a heavy smoker or not. What's there is definition of heavy smoker. If you smoke, what they call, like, over 20 pack year, how we calculate this? We see how many years you smoke, let's say 10 years, how many pack? 2 packs a day. 2 by 10, it's 20. If you get this number by this way, let's say if I smoke like 30 years and I used to smoke like 3 packs a day, how many pack a day? How many pack year?
90.
Would be 90.
Yeah.
Oh, so this is what if you reach 20, this is heavy smoker. The definition, and there is reason behind this, if you reach 20, let's say if I'm 20 years old or 15 years old, I smoke like 2 packs a day, and now I'm 30 years old. So 15 years by 2, 30 pack year. Even I'm 30 years old, but I'm at high risk to have the disease. I'm a smoker now, but I don't have the disease. But at 30 years old, I'm a smoker and a disease. I have a disease. And this is a disease, it progresses. Whenever it starts, meaning what? Meaning your immune system is overwhelmed and is losing. And this is what it means. Any question? Sure, go ahead.
I have the chronic bronchitis, and that's still considered COPD, right?
No, chronic bronchitis is, by definition, it's part of the COPD.
It's part of it?
Yes, it's COPD. You have bronchitis, chronic bronchitis, and emphysema. Both of them COPD. This is a general term.
So it's not gonna change over to emphysema, or?
It depends. And let's say if a patient, if you take care of yourself, and this is, and let's say if you smoke or something, or you have exposure or for any reason, and you decide to take care of these factors, and you do not have emphysema at time 0, then, and you take good action, most likely you won't have the emphysema later on. But it depends on what you're doing. Yes, please.
My husband's on acetylcysteine, and evidently they're not manufacturing it anymore.
They do have some.
The VA can't get it, and I call Walmart.
Now we have, I think, Ashley, get it. Yeah, we do have some.
They don't have the nebulizer.
Nebulizer, you mean, or liquid?
The liquid.
Liquid
Liquid, yeah.
is hard to get.
No, it's. What about tablet?
You can get the tablet though.
Yeah.
The tablet's over the counter. You can get a tablet over the counter.
You can?
Yes.
And it's not expensive.
Is it called the same thing?
N-acetylcysteine. And it's over the counter tablet. You can get it pretty much at, I think Walmart has it, I've heard before, or you can order it online even. And then your dosage will change a little bit, so you can call us.
Because it does help, to send the new business.
Yes, it does help, correct. This is not for everybody, but for every COPD, I mean, if you have like flare. Sorry, go ahead.
I'm just going to ask you about the nebulizers. Are they of any help to COPD?
Nebulizer, we have 2 types of nebulizer. We have rescue inhaler, albuterol and atropine.
No, not that. I'm talking about not the little.
Puffer?
Not the puffer, the kind that you have a mask and you.
Yeah, we have 2 types of it.
Yeah.
We have rescue and we have maintenance. Rescue for albuterol and ipratropium, it goes with the nebulizer.
Okay.
This is, we know it's temporary, mainly albuterol, it stays in your system for a couple hours, like 2 hours, 4 hours or so. And it's not considered as maintenance treatment. Other nebulizer treatment, Brovana and budesonide, this is 2 medications, can be used in certain cases, but this is maintenance treatment.
Okay.
So, what's the question?
Just whether a nebulizer is worth having or not, or just regular standard puffers.
It depends.
Or both. I mean,
yeah, if the patient is able to take good inhaler technique, no difference. if the patient is not able to good inhaler technique, like to suck it all the way down, and because of the severity of the disease, then the second option is to give him nebulizer. Nebulizer, it's easier to take it. I'm not talking about Duinab or albuterol. Nebulizer, we have several medications goes to the nebulizer. Nebulizer is a machine, but whatever it goes in.
Yeah.
So, but if the patient is not able to take good nebulizer, the good effort, is not able to use good technique, then the nebulizer would be the second option. Yes, go ahead.
My bronchitis brought me to you. You know, I had colds in the past when I was younger, you know, it was called bronchitis, but I never thought that bronchitis was as bad that drove me to see you, okay? And, 3 months, couldn't sleep in my bed, coughing and coughing. My wife gave me some tea and that, and then you told me about the nebulizer, and I took that and it helped. And then of course you got me on Spiriva and that other one there, I can't pronounce it. But that was terrible. I was just going to bring that up to you because...
Yeah, but the good issue with you, your immune system is good.
I can't believe it was that bad. Coughing. For 3 months, just before Christmas, it all happened. I'm going to March like this. And I'm coughing like crazy, couldn't sleep in bed.
And you go ahead.
Slept in my chair.
I had 17 years.
For our patients, is that
You had what? 17 years?
Yeah.
carrier, what is the treatment?
Well, I'll tell you, Doc's a good man, I'll tell you. He's good for people.
Alpha, this is good questions. Not, we have different type of alpha-1, this is a very important question about alpha-1 antitrypsin deficiency. We have carrier and we have the disease. And we have patient at risk. So if you have the disease, then we have to go to the what they call like augmentation therapy. Augmentation therapy, this is like medications, you give it over 1 week or 2 weeks, like daily to improve the level of the enzymes. And there is a treatment of this and literature supporting that, and the outcome actually is very good outcome. And the issue with this treatment, it's chronic treatment. You should be on this treatment forever. If you have the gene, you don't need to, and the level is okay, you don't need to have treatment. And as you know, it's not like this is very wide, like you have different type of this alpha-1 antitrypsin deficiency. It depends on the gene. And if the worst form is ZZ form. So if the level would be very low, this is a more severe form. All the others, it depends on the level, and we check the level enzymes in the system. If the level is okay, from this case you go case by case. But definitively, if you have like the level is low and you have the disease, especially if you have like the symptoms, then needs to be on treatment. Go ahead.
You said that if you have COPD, your immune system is constantly active.
Correct.
But that constant activeness can itself cause problems.
Yeah.
What can you do about that, if anything?
To control the COPD. This is why we tell this is COPD controlled or not controlled. What I mean, let's say I have a COPD now and I'm smoking. If I continue to smoke, yes, because I expose myself and I keep waking up my immune system. Let's say I stop smoking and I control my COPD. I have the COPD, but I don't have any symptoms and I'm not smoking. Then the immune system is not completely back to normal, but it's not as active as if I smoke. In this case, this is what they call like controlled situation. The worst case, if you have COPD and it's not controlled symptoms-wise and exposure. This is meaning your immune system is very active and it will affect your cholesterol, it will affect your heart, it will affect your vessel, it will affect a lot of other systems. Yeah. Yeah, go ahead.
Smoking and smoking marijuana. You're doing double duty?
Correct. This is marijuana is as toxic. Actually, it's more toxic than the regular cigarette. It is. So, and it's for regular cigarette we wait for 20 pack here. For marijuana, much less. Even if we have like 5 years marijuana use, it's considered as significant. Yeah.
I've talked to a lot of people that have tried marijuana, and they claim that it really helps them. And I
COPD?
I can't go against marijuana because I hear so many people saying it helped them in their problems, you know, physical or whatever, muscular.
When we go, we have like sometimes like this is what they call like subjective versus objective. Let's say you tell me how you feel. I feel okay, but I may have like I'm not able to walk, but I feel okay. This is subjective. But if you check me and you see like the breathing test is like 10, you tell me no, you're not okay. But I'm telling you I'm okay. So this is one when you go to like a lot of medications. When you ask, we have like subjective part, how you feel with this medication. Oh, I'm happy, I'm doing fine, But when you go to the objectives, and this is what they call evidence-based medicine. So evidence-based medicine, you have to have objective data to show it. This is, I prove to you, I swear, this is what I'm doing right or wrong. So in marijuana, we know that we have a lot of literature about like, especially from lungs, it's more toxic than a cigarette, and no question about it. The questions, people like, they come like COPD and they continue to smoke. When you ask them how you feel, they will tell you good. And if you ask them about like function capacity, shortness of breath and symptoms, not majority, I told you, 80% of this group, they won't, doesn't mean they are lying, no. But they don't realize, they don't how we can say this one, realize like about the symptoms. Yeah. Even though like you tell him, are you able to walk like 200 feet? He will tell you maybe 10 feet. He will tell you no, but he feels okay. This is, they call like subjective.
Doc, I had an uncle, he had 4 years of combat, and he smoked 5 packs of cigarettes a day. And so he came, New York, lived in New York, he's gone now. He came here for my parents' 50th wedding anniversary, and he's got a beard on, he's playing with the beads. And I said to him, Uncle John, I says, whatever made you, did you quit smoking? He said, yes. And I said, what the hell ever made you quit smoking? He says, I got nicotine poisoning.
Yes, sir.
What is nicotine poisoning?
Okay, this is nicotine poisoning. This is, as I said, this is, people feel like this. No, we know this is nicotine poisoning. When you smoke, this is a kind of addiction. What nicotine, it goes to your system and it works in a certain way in your system. They call like receptors. This receptors is not very common now, but if you get exposed to nicotine too much, this is why, like let's say normally you don't smoke. You start smoking today, in 10 years or 20 years, you expose yourself to nicotine. What happened, you got what they call like activate a receptors in your system. These receptors, if you decide now 1 day or 1 week not to smoke, this receptors needs nicotine, and this is what they call addiction, like drugs, like alcohol, and even a lot of medication like benzo and Xanax and a lot of other stuff. It works the same way. Nicotine toxicity per se, I don't think this is, unless in medicine when we talk about toxicity, if you get like those and your system is not able to handle it, meaning you're sick, but there is nothing called like toxicity chronically and he's walking around talking and nothing happened. But what he meant like maybe he was addicted to it. Any more questions? Okay, thank you very much.